that is less aggressive and definitely more hands-on and more sensitive to the patient's movements kind of treatment. I think that this works really well for those who are in more acute pain. So for me, the strain counter strain I think is really ideal and fits a niche that isn't really covered as well with other treatments. For instance, if a patient comes in with acute neck pain and they can't tolerate soft tissue work and they can't tolerate exercise and they can't tolerate movement, and I certainly have had that. So I feel like this really fits a niche for those who need those small movements and the lightest touch besides myofascial stuff. Even sometimes they can't even tolerate the myofascial, but they could tolerate a little movement with their head because you know very well that they're walking around and they're moving their head. So you know that they can do that at least. They just may not be able to tolerate the sustained touch and stretch position of myofascial versus a tender point and then moving into a position of comfort and then not putting any pressure on it, but just letting them completely relax and then coming back out of it.
Do you find that the patients like already know those positions of comfort?
Not necessarily. I think that they will maintain a protective pattern, whether they're conscious of it or not. I do think that they kind of put themselves in a position like that, but there can be multiple points in the body. Therefore, it's hard for a patient to maybe satisfy positions of comfort for every particular point. So I think, to me, it's a treatment that maybe treats more head to toe. If you really look at it as a whole, and if you see the practitioners who do strain counter strain, they will treat the person as, you may come in with shoulder pain, but they may end up doing the treatment down in the lower extremities. You know, maybe much like acupuncture, where they do different parts and there's meridians throughout your body and you can affect a different part of the body by stimulating that in a different area. Yeah. The theories of it, of both MET and even strain counter strain, I mean, I'll be honest with you, they're a struggle for me to explain. I do them so often that they make sense to me when I'm performing them and doing them, but having to actually verbalize and explain to them, sometimes I think that's challenging. It's taken me many years to kind of even get I get the concept of strain counter strain in terms of position of comfort. I mean, when you look at it, that's really the point of it, whether it's a fascial issue or whether it's the proprioceptive theory. The point is you're moving away from a position of pain into a position of comfort and even further comfort. And that's really it right there in a nutshell. So if you try and stretch a person and you try and lengthen their hamstrings, but they just can't go that way, then you may need to do some other treatment that brings it the opposite direction in order to allow a stretch to occur. So, and that's just a simple example like that. So, I do kind of see where you're coming from.
I have one more question.
Sure.
When you're finding tender points, are they, the study, like by Jones, when he said he identified close to 200, are the tender points in specific places on everybody, or are they variable? Like each person can have their own 200 tender points?
No.
They're specific
They
body
are
places.
specific body places.
Because I got that with like the AC joint and some of those particular, but then it's all over the place.
Yes, there are specific places to find the tender points, yes. It is
Okay.
not patient-directed in that aspect.
Okay.
Yes, yes. He identified them, and then he would not only identify a point and a position of comfort, but then he would go ahead and check that point on everybody else. And he would, I don't know how many times he would do it until he would actually write it down and call that a point. But it would be the same point that he would do on everybody, and it would be the same position that he would do on everybody before he would write that point down. Yeah. And so there are books and posters and apps that will show you all the tender points throughout the body. And Jones's treatment is more musculoskeletal, even though they have a fascial, musculoskeletal, fascial strain, counter strain, and cranial, and a lymphatic, and veins and arteries and nerves and all that. They kind of go into it in a much bigger sense. His is called more the classic, and it's probably the one that I practice the most. It's the one that I've done the most of, even though I've taken some of the other work. It's the one I come back to time and time again for me, because it seems to work for me. And I would say that that's a good place to start, is the Classic, and that's what I'm gonna show you guys today. So I'm hoping that maybe by the end of the class, you'll kind of have a better sense of what it does and how you do it. And it does have a specific protocol to it. So, yeah, that's my plan for today. Okay. So, as I think I stated in the beginning when we started this class, there are some things that will make total sense and some things that will maybe not your bag, to do. But don't put it aside, because it's kind of surprising how sometimes when you say that that's not a treatment that I can see myself doing, how 10 years from now, it might round back to it and you might find yourself doing it. Happened to me a couple of times. I don't know if any of you guys are familiar with Watsu, which is a water treatment. It's name is based on water shiatsu.
Oh.
And you're basically floating someone in the water, and it's based on
And stepping on them?
no, not so much there. You float someone completely on their back and you move them around in different ways.
Oh,
Water.
okay.
Yes.
I want that.
Yes.
You too.
Yeah. And it's based on meridians in the body, and you do the stretching and whatnot. But anyways, my first introduction to it, I remember leaning over to my coworker and I said, I will never do that. Fast forward to 5 years later, that's what I do. So,
Great.
totally different, yes. Okay.
That's cool to me.
I guess I'll just keep sitting here. So any other questions though, at least on what we talked about yesterday? Because I'll go over the protocol a little bit.
Will you send us the link to the
The Zoom, yeah. I'll check.
recording?
Oh, yeah.
I can help you find it if you
The
need help.
Zoom lecture, you mean?
Mhm.
Yeah. Oh, if you want to help me find it,
Yeah.
that'd be great, and then
I
I
got
would
you.
know, because Christian just did it for me.
Cool.
Yeah.
I got you.
A few questions about, like, the MET.
Yes.
So, one
The
was
MET versus the string counter straight, or just separate MET?
just separate
You got
MET.
Gotcha.
So the spinal portion of the PowerPoint,
Yes.
the type 1 and type 2, that's not very clear to me, like, what is that? I don't even, like, have a concept of what that is. Like, is it just a coupled movement that
It is.
sometimes type 1 would be the rotation and the bend are to the same side,
Right.
and then
Type 2 is opposite directions.
that's it?
Yeah,
all it is?
that's it, that's all it is. It's really just, when you start to look into the spine itself, then you look at what the vertebrae does when you do certain movements. And in type 1s, you see a specific pattern, in type 2s, you see a different pattern. And so that influences how you're gonna treat them in terms of taking up the three-dimensional barriers, cervical versus thoracic. And the more common is type 2s, and so that usually means that you're gonna work on just one specific vertebrae versus a couple. So in the cervical spine, you might do it a little bit differently, because side bending rotation might be the same direction, or in the thoracic, it might be the opposite. So don't worry about it, it was only an introduction.
Okay.
It is not an expectation that you guys know how to do. I would have spent way more time on it
Okay.
Oh,
if we had done it. So when it comes down to it, that is just, right.
Okay.
Yours is, right, take that off the plate.
Okay, so
Yes,
speaking of
especially
things,
off the
I have another
checkout plate.
question.
okay, you go.
Yes,
Yeah.
but I brought it up because I wanted you to, and maybe it was just a little bit too much, too kind of broad and big, so, but mostly I wanted you to see how it's utilized in a step above the contract relax.
Okay.
Really, it was the
Step
point
is
of that,
relax.
yeah, it
Okay.
was just kind of like see it in a bigger picture, because that's
Okay.
really where, Dr. Mitchell came up with that, is he focused on the pelvis and the spine, and so that's where he did his practicing, before he moved it into the extremities and turned it into more of what we see today, which is a contract relax, but with that premise of the pause in the middle in order to gain a little bit further motion or mobility.
Okay.
And so,
My
yes,
other clarifying question on that, the PIR and the IR, the difference and what the muscles are doing and which muscle group is doing what. So with PIR, let's say they have a tight tricep or something, so flexing is,
so the example that
difficult.
was given was they couldn't extend, though they
Okay,
were limited
so we'll
in
go with
elbow
that.
extension, yeah,
so let's say limited in elbow extension.
yeah,
So you're going to
which one?
push into, the therapist for PIR is going
PIR.
to push into extension and they're going to be flexing,
Exactly,
which means that in terms of the movement that they're restricted in, they're using the antagonist to flex,
Versus
and they're
the
not using the
agonist.
agonist, the
Right.
extensors. But then in another slide, it says use RI if they can't do an isometric contraction.
Because it's
With-
done in mid-range,
So if,
and it's the opposite structures.
so,
So
but,
the patient would be moving into activating
so
the
it's eccentric
biceps,
bicep for
versus-
extension.
right, versus the opposite, right?
Oh,
The patient
okay.
would be moving into the barrier themselves, where the
Mhm.
therapist would be going the opposite direction,
Right, but they're
Switches.
using an eccentric
lengthening,
of the antagonist.
right.
Okay,
Mhm,
thank you, that's
mhm.
where that mid-range.
Yes,
Okay.
yes. Again, we'll just focus on PIR though during checkouts.
Yeah, I just wanted to make sure I
But
understood.
it's
but-
good, yes. It's good to kind of think that through, yes.
So speaking about checkouts,
Yeah.
And
what,
I forgot, I'm so sorry, after I left and I was driving home, I was like, oh
Yeah.
crap.
That's what
Greg
I,
said, can we do that?
what do we need to know?
Yes, good question, yes. And so what you will be having your checkout on, of course, is peripheral nerve testing, as well as MET and strain counterstrain. Okay, so in the lecture, there was a lot of lab activities at the bottom. And I'm just gonna choose a couple of those. We will do more than what I'm gonna actually have you do during the checkout, but I would tell you exactly what they are. And during the checkout, I will tell you what point you're gonna treat. So you don't have to be palpating and poking and deciding you're gonna do this or you're gonna do that one. I'll tell you exactly which one you're gonna treat.
So are we gonna have to know one of each of those for, like, for example, like if we walked into our checkout, you're gonna say, okay, well, you're gonna do PNF on this and MET on this and strain counter strain on this, ready, go? Or
Yes,
is it
exactly.
like an imagined sort of scenario where it's like you're walking in and this is your patient and they've got some nerve issues, so you're going to focus on PNF versus someone who's got flexion issues and you're gonna focus on METs or,
So likely the scenarios will include two things. They will include a nerve mobilization testing and an MET treatment, or it will include an MET with a strain counter strain. All of them may include the home program portion. So in other words, you may be giving a glide or a slider as the home program. You may be giving a MET to improve external rotation in a doorway. You may give a home program for the upper trap and strain counter strain. And I do have a handout with all of that listed.
cool.
Oh, that was my other question. When, I remember you saying, or you might wanna have them do the stretch themselves at the end of an MET, and I was like, what? I couldn't remember why, like, what part of the treatment that was for, like, go home, that's the go home part for?
Not necessarily. I think of
Okay.
it as in you've done MET and now you've gained range. So now you would want to get up and
Mhm.
actually have them do something
Oh,
that
right there,
pushes
right
into
after, okay,
that
yeah, that
new
makes
range
sense.
that they have.
that makes sense,
Yeah.
okay.
Okay. So I have a couple handouts for you guys, all right? So I think that might help clear some of this up too. I have the rubrics if you want to take a look at it. I also have kind of a 1 through 12 kind of step process on things to kind of think about when you actually do the checkout, this, all the way down. And then I also, because there could be a low back scenario, I did print out, because I'd forgotten to last time, the tensioner and glides for the slump testing. So I have that as a handout for you guys, and also a handout for the strain counter strain home positions as well. Okay? I know it maybe sounds like a lot, but let's go through the strain counter strain, and it'll start to, hopefully it'll kind of become clearer as we're practicing it. Okay? All right, so any other questions that you can think of? I haven't turned my body, I haven't
we gotta
rotated over
remember
here
to
to
do
Naomi.
checkout times.
Yes. Do you want to keep the same times that you had last time, or do you want to change them up?
I'd rather go earlier if that works for
Works
you.
with me, yeah.
A little later.
Okay, so you guys want to go at 12:30?
Yeah, we went last time, right?
Yeah.
So yeah, either then or middle, either one.
I think I was first to speak up last time, so I'll let you two choose.
12:30.
I don't have a preference.
I don't
Naomi,
either,
do you have
yeah.
a preference? Whatever
Is
our
it-
time options,
Is it an hour for both of us?
Yes.
Yeah, first one.
so
So 1:30 or 2:30?
Mhm. Okay. That leaves you at 2:30.
who's,
Wait,
uh,
you two
Yeah,
are
Yeah.
going at, you two are going at what time?
I don't know.
Okay.
What are the options?
Naomi's going at 2:30.
Okay, we're
Okay.
going at
Okay.
1:30.
Great.
Okay, yeah, because I just have, just you guys, yeah. Okay.
1:30 it is.
So you guys are 1:30,
Okay.
you guys are, no, wait,
Yeah.
you're 1:30, you guys are 2:30.
I don't know, what's your paper say?
We'll take 2:30, they can have 1:30.
Okay.
All right, Ally.
Decision.
Ally and Morgan, 1:30.
Okay,
Andrea and Naomi, 2:30.
thank you. Okay, we have it, 12:30 you guys, 1:30 you guys, 2:30 you guys, we got it, okay, super. All right.
Decision making is hard.
I will tell you that this was a class 5 years into practice for me, or more. If you guys want to turn on. This is the class for me that changed how I treated. This one definitely was, strain counter strain, was probably the thing that kind of put me on the path to doing much more hands-on therapy than any other class I'd taken before that. After this, then I did all the strain counter strain classes, then the MET classes, and then some myofascial stuff, and then kind of progressing from there. So what this did for me, what I think this class is really beneficial for, is that you have to be really good, you have to get really good at your palpation skills. You have to be able to know the structure that you're on, or the tissue you're on, or the joint you're on, and you need to be able to understand and feel the sensitive changes that occur when you move someone in different directions. So if you want to kind of get better at that, this would be it. So I'm gonna have one of you come over here and lay down for me on your stomach, if you don't mind. I'm not gonna look at anyone in particular, I'm just gonna let you
What are you
guys-
working on?
We're gonna start with the first point to treat.
Are you gonna be focusing on the suboccipital region? Because I will jump into that in a
You
heartbeat.
got it, come on up here, we're calling your name.
Okay.
I'm gonna let you first sit.
Thank you. What? I'll figure it out.
Okay, so the protocol, just the protocol for the treatment, and this is really important because it is specific, is that you first find the tender point, okay? Once you find the tender point, you'll assess whether or not it's a true tender point by a patient's kind of jump sign or by their subjective pain complaint, okay? Followed by, you'll move them into a position to reduce that tension, and it's very specific on the directions that you turn the head and rotate the head and flex or extend the body, okay? Once you get most of that position set where you feel maybe the mobile point and the position of comfort are the same. So you'll kind of hear me say it both ways, okay? The mobile point means that it's the point that you have found that has the least amount of tension in that area where they were tender. It's where they will tell you that they have less pain, or no pain, or they feel much better. Once you find that, and you've checked it, and they say, yes, it's fine, then you will hold that point for 90 seconds. Yep.
Do you release the pressure but monitor it before moving into position of comfort?
No, I
After?
palpate the point when I find it, and I haven't even moved them. I move, and then right then I take the pressure off, I move them into the position, then I will check the point So that's the second time you'll check it. Once you check that point and they tell you that it's less painful or they're comfortable in that position, and or both, you'll hold that for 90 seconds. Once you've held it for 90 seconds, you'll take them out of the position very slowly back to neutral, and you will check it one more time. So there's 3 times that
Do you mean hold the
specifically check it.
position or hold the point with
No.
pressure?
No, you always monitor the point. Okay?
So when you say hold it there, you just mean the
I
position?
meant just. What
Hold
did I
the,
say?
hold the
Did I
position,
say
you
hold?
just said it, and I wasn't
Okay,
sure if
hold
you
it.
meant a
Okay,
tender point,
position,
like,
tender point, okay.
cause you've
yes.
touched it twice, but I don't know when you released the second time.
Right, okay, so let me start from the beginning again, so we get it done. Okay, so you find the tender point by palpating, okay?
Mm.
Good. Now you take that pressure off, but you leave your finger there, you're monitoring the point. You're gonna move them to a position where they have less pain, okay? Then you will check it to make sure they have less pain. At that point, if they're telling you it's a go, you'll take the pressure off and monitor the point for the entire 90 seconds without pressure
I
on
see.
the point.
Okay.
Then you'll come,
So we hold them in the position.
The- The pain, when you're asking them if they, in the position of comfort, is there relief of the pain? Pain at the tender point or pain at their original source of pain?
that should be the same, you haven't moved
Yeah.
your finger.
But I thought the tender point does not necessarily represent where the pain is located. It could be
Mhm.
opposite.
Mhm.
Right, but you would find a tender point in that opposite area. She may have more pain in her neck, but she may not have a tender point in her neck, but she may have a tender point in her axilla or first rib or SCM on the left side.
So you find that,
Yes,
release,
release it,
move them into a position of comfort while monitoring that.
yep.
And then when you ask them if their pain is relieved, pain in the neck or pain where the jump signal was?
Pain where the jump signal is,
Okay,
yes.
thank you.
Yes. Yes, so far? Okay. And then, so, once you get them into that position and you've assessed that their pain is less right there at that particular point, you take the pressure off and you monitor it, holding it for 90 seconds. After that 90 seconds, you'll bring them back to neutral, still monitoring the point with no pressure on, all the way back to neutral. And at that point, you will put pressure on and check it. And then they should be able to assess for you whether or not that has reduced their pain. So if you have pain in the neck on the right side, but you only find tender points on the left side, and that pain goes away during the treatment of the tender point, they should be able to tell you that maybe their pain has reduced in the neck, or maybe it's still there, but they're demonstrating improved mobility, even subjectively. It may take a while. We know that the pain sensations can linger almost longer than the dysfunctions can be there, or the injuries can be there. So sometimes it may take a little while for the body to kind of get used to being back in a better position. Okay, so if they feel that this is less tender, that may help them feel that this is less tender, or they may show an improved range of motion, or even strength. I've seen people all of a sudden have all their strength back after a strain counter strain treatment. Yeah, okay? We will keep going over this again and again and again, so what may not be clear will become clear when you're actually working on the patient, okay? So I'm gonna have you lay on your stomach, face down. So this is just a quick demonstration for where to find the first point. So if you come to the base of the occiput, just want you to be able to see this. So I usually come in to right where the occipital notch is. You'll feel as you find the very center of the skull, the very center of the occiput, that if you run your fingers alongside there, you're gonna find the ridge of the skull, right there. You wanna be in the soft tissue, not on the ridge, not on the bony structures, you're in the soft tissue, right down here. So, we're looking for the first point. You find your center mark, and then that just kind of gives you a landmark so you know where you're at. You move about 1.5 centimeters lateral, and then you move an additional 1 centimeters lateral. So you're only moving out really not that far, because as you can see on the screen, there's more than one point along the base of the occiput. And this one we're gonna do is PC2, which is the one that's farthest out. He named these for various reasons, but primarily A means anterior, P means posterior. The numbers reflect the spinous process that it's closest to or the joint that it most connects to. If it's not a specific AC point or first rib or spinous process down the spine itself. So find your, when you do this, I'm just gonna have you start with the 1, okay? 1 point only. Have them lay on their stomach and palpate back here so that you can kind of feel where that notch is, and then move your fingers out alongside the edge of the skull, and then find kind of where that sits and move right down into the soft tissue. Once you kind of get a feel for what that is, flip them over and do the same thing. Find the center and move out from there, okay? The point is gonna be approximately, slightly different on everybody, but approximately, if we look at the center right here, and you know that 3.5 centimeters is not very far, it's about here. Okay, and you can palpate yourself. So a true tender point means the blanching of your fingernail. And I find that that's probably not, that would be a very true strain counter strain point. And there's very few of those that I've actually come across who literally jump at the lightest pressure. Most people need a moderate, light to moderate amount of pressure. And depending upon how much tissue you have to move through, you may have to move a little bit further into that. Okay, so don't be afraid on the first try that you're maybe using too much pressure. So kind of palpate back there and see if you can find if there's one side that's tighter than the other. Do not push down with both at the same time. Make sure you check right and left, separate. You won't know if you're pushing down with both if one side's tighter than the other. So if you don't have a tender point along here, just pick one, okay? So go ahead and flip over for me.
Jessica, so there's identified tender points on all people in these locations. If the
Yeah.
patient is not experiencing any pain, is it like there but just inert? So no matter how much pressure you put on it, it's just gonna feel like any other tissue part to the patient?
Yeah,
Okay,
yeah,
so you're not necessarily gonna get a jump or grimace response out of Andrea here?
no, mm-mm.
Okay,
That's center, so you can feel that pressure that I'm using right there. So you
Mhm.
kind of have an idea for you.
That's more pressure than you were applying when I was prone.
Before, yep. It's easier to apply pressure upward than it is to go down.
Sure.
So the weight of the head also adds to that pressure. So if I go center here, and then move my fingers out slightly laterally, so here's a quick check on right and left. And then if I go a slight bit further, here and here, if I have to pick between the two, I'd say left.
Uh-huh.
That's just ever so slight difference. I wouldn't say you have a true one, but just the tissue texture felt a little different on the left side versus the right. Now, that could be two things. One, the way her head is resting on her braid. It's shifting.
Oh, hold on,
No,
wait.
it's okay, it's okay. I'm just saying that it could be causing her to be a little bit tighter because that side's up a little bit higher.
Mm.
Also, there's a divot in the bed, so her head might not be resting center.
Mm.
So,
But that is the side that gives me more grief.
okay, so maybe we'll just pretend that that is for sure the side, okay?
It's the
So,
side.
I have identified a point by pushing anterior up, okay? So now my finger is monitoring it. Do you feel much pressure from my hand right now?
No.
Okay, so now I'm in that monitor position right there. Now I'm gonna go ahead and move her into a position that I think might release some of the tension. So if you follow along, if you have handouts, or I'll put them up on the screen here a little bit too, you would tip her head back into extension, back into here, yep. And you can use it by using your hand on the head to direct the pressure and how much extension. You just wanna extend to the level of C1, which is not very much at all. Okay. So I'm gonna go back to center here, and I'm just gonna monitor the point as we're talking for a sec, because if the point is on the front of the body, it's treated in flexion. If the point's on the back of the body, it's treated in extension, okay? So in her case, we're gonna tip her head back a little bit. She helped me out there, and she's not supposed to.
Sorry.
It's okay. And already, because the point is just slightly lateral, more midline than actually lateral, it will already reduce a little bit of the tension. So if I check back here, it should be slightly less, but it may still be there.
I mean, it's tight always.
Okay. So in her case, maybe a little bit better. Now, what I would do is rotate her head away from the point and side bend her also away from the point, okay? And then that's it. from there, that's where I think maybe that might be the mobile point, which I still have her in a little bit of extension and kind of moving slightly. And it may take you a few seconds, it may take you up to 10, 15 seconds to decide if you're actually in the right spot. You can feel me moving ever so slightly,
Mhm.
yeah. So I'm moving so slightly, I'm putting her slightly in extension at the same time I'm side bending her and rotating her, and kind of working between all three of those to decide which gives me the most. And then what may happen is you'll get a therapeutic pulse, which means you'll feel like a little pulsing underneath your finger. Don't use your thumb. That would kind of give you a false reading. You may feel a little bit of heat. You may feel just a softening under your fingertips. That's all there is to it. Do you feel me pushing on the point?
Is
No.
the monitoring pressure that you're doing right now, like, would that be enough, like, to blanch the skin, or is it super, super light?
Super light, just like what you have your hand
Just
resting
barely
right
there.
there, just barely
Okay.
there. Yep, and that's because a lot of times when patients come back to neutral and you check the point and it's better, they sometimes don't believe you and say, are you sure you're on the same point? And you can say, yes, I did not move. So it's a way to kind of make sure that you're giving them the feedback that they need. So you hold it for 90 seconds, which is what we're doing here, okay? And if you don't have a clock, if you don't have a watch, don't have a second hand around you, which unfortunately our clock is still out, so it would have been perfect for everyone to be able to watch that 90 seconds. I have found that singing the Jeopardy song a couple of times, twice through, is about 90 seconds. So as long as it's not fast, but you just kind of hum in your head or do, 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 and so on. Okay. So and for me, sometimes I might be a little shy of 90 seconds, but I stop. Sometimes when I feel that pulse kind of release, well, we're going to say that's 90 seconds. We're going to move her out of the position really slowly back to neutral. And get her set right there. I still haven't pushed on the point yet. I'm adjusting to make sure she's back in neutral. And now I'm going to check the point. May or may not feel better.
It doesn't feel as angry as it usually does.
If I compare it to the other side.
Now that side feels tighter.
Now I was going to say, now the right side feels a little bit different.
Huh.
Yeah, so that's the general idea of it. So what I'm looking for you to do is to just palpate back there, number one. Find a point, even if it's not tender. Run yourself through the protocol, and I'll come around to kind of check in with you guys, okay? So the first one is just about kind of getting that down, and then we'll kind of start stepping it up a little bit and doing a couple points at the same time.